Hello everyone, I'm Shivshankar Challa and I'm here to speak about the Gaucher's disease of the bone, which is a rare metabolic disorder affecting the bone. Coming to the learning objectives of the presentation itself, I will be introducing this disorder, following which will be the epidemiology of the disorder, after which we will be speaking more of the pathogenesis and the genetics involved. Later on, it will be the most important part of the talk, which is the clinical manifestations in the bone itself, followed by the lab findings which help in the diagnosis of this rare disorder. There will be quite a few differentials which actually follow the same pattern as this particular disorder, and hence we'll be speaking about that. And last but not the least will be the treatment options available in front of us. Coming to the introduction, which I will be discussing as a clinical scenario, we had a 5-year-old child who was brought by Ashkenazi Jewish parents after a familial marriage within the family with abdominal pain and distension, which was progressing since the last 2 months. There was previously no recorded medical issues for the child, and the examination findings came back with hepatosplenomegaly both on clinical exam and also on diagnostic ultrasonography. This was the clinical picture of the child with an abdominal distension and hepatosplenomegaly on clinical exam. Given the busy clinical practice that the pediatricians have, they have a common differential diagnosis when it comes to hepatosplenomegaly, and the common ones, which are infections, a possible congestion in the liver, or an anatomical or an infiltrative disease with a hematological background, were the differentials which are available in front of the pediatricians. To investigate further, bloods, bone marrow aspiration, and liver biopsy were then done on this child. The bone marrow aspiration then came back with wrinkled cells which were more suggestive of lipid-laden macrophages as seen in this picture. The liver biopsy then came back with wrinkled cells within the fibrous septae of the portal tracts, which suggested an infiltrative pathology. The conclusion was then a lipid storage disease which presented with hepatosplenomegaly and is compatible with Gaucher's disease. Gaucher's disease itself presents as three types, but when it comes to the clinical manifestations in patients, it actually presents itself with splenomegaly, hepatomegaly, and thrombocytopenia in decreasing frequency. But surprisingly, it also presents with osteopenia followed by bone pain, which are quite common when it comes to the clinical manifestations. This is followed by anemia and also bleeding propensity owing to the thrombocytopenia with which it actually presents. When it comes to the genetic part of the pathology, it is actually an autosomal recessive disorder which is due to the mutation in the gene glucocerebrosidase, also known as GBA1, which is located on chromosome 1q21. Coming to the pathogenesis of the disorder itself, it is due to the deficiency of the lysosomal enzyme named glucocerebroside, which is also known as glucosyl ceramidase or acid beta glucosidase. This leads to the accumulation of glucocerebroside or the glycolipids, which form an important integral part of the cell membrane of the human body, and the levels of these are actually expected to reach up to 20 to 100 times the normal limits. As mentioned earlier, Gaucher's disease itself is due to the deficiency of glucose cerebrosidase, which is an enzyme involved in the degradation of the glycosphingolipids, which is the glucosyl ceramide, which generally is supposed to be degraded within the lysosome into glucose and ceramide, and the deficiency of this particular enzyme leads to the accumulation of glucosyl ceramide within the macrophages. The glycosphingolipids, which are supposed to be degraded within the lysosomes of various cells, are now getting accumulated, and the sweeper cells in the body, which are nothing but the macrophages, are trying to clean this up, and in the process there is an accumulation of a lot of lipid within the macrophages themselves. The accumulation of this lipid-laden macrophages in the spleen, the liver, the bone marrow, the bone and other tissue and organs leads to the hyperplasia within these organs. The lipid-laden macrophages themselves are called the Gaucher cells, and the disease gets its name from this. The Gaucher cells and the neighboring macrophages then overexpress lysosomal proteases like cathepsins, IL-6, interleukin-8 and interleukin-10, which leads to the pathological process of the disorder. As mentioned earlier, the interleukins will in turn lead to a hyperplastic tissue response with the macrophages getting accumulated within these organs, and this results in additional increase in organ weight and volume, especially in the liver and also the spleen, and the increased bleeding tendency in these patients with especially the Gaucher disease type 1 is related to thrombocytopenia, the coagulation abnormalities and defective platelet function. The Gaucher cells then tend to get accumulated within the liver or the spleen and the bone marrow, which form the reticuloendothelial system of our body, and the disease is then causing an hyperplasia of these organs involved. After speaking about the pathology, we can conclude with various means by which the patients can present when it comes to the Gaucher's disorder. And when it comes to the reduced hemoglobin, the patients can present with anemia and fatigue, while a reduced platelet count will obviously lead to bleeding or bruising all over the bodies. There is also a chance of a reduced lung function with the macrophages getting accumulated there, which could lead to shortness of breath, and patients can present with acute pulmonary dysfunction. The liver and the spleen enlargement due to the macrophages getting accumulated could lead to a hyperplastic liver and spleen, and hence a hepatosplenomegaly, and hence the abdominal discomfort and the distension. The reduced bone density is owing to the osteopenia, and this could also be due to the bone marrow infiltration by the lipid-laden macrophages. This in turn could lead to bone pain and fractures within the pediatric age group, and it should be a part of the differentials when it comes to fragility fractures in the pediatric age groups. Since we'll be concentrating more on the orthopedic point of this disorder, we will be discussing on what exactly happens with the bone. In the bone, the disorder affects the mineral density by decreasing it, and there is a marrow infiltration by the lipid-laden macrophages. This in turn leads to bone infarcts which cause weakening of the bone, which in turn leads to the frequent fragility fractures that we actually see in this disorder. When it comes to the decreased mineral density, this is owing to the fact that there is an overproduction of the cytokines by the activated lipid-laden macrophages within the bone, which leads to an abnormal osteoclast regulation and hence a failure in the bone to achieve peak bone mass, and hence a decreased mineral density or osteopenia. When it comes to the bone marrow infiltration itself, its eventual result would be a bone infarct, and this is happening because of marrow fibrosis, which leads to osteosclerosis, and this in turn results in a localized loss of hematopoiesis and hence the reduced hemoglobin and anemia with which the patients actually present with. The marrow fibrosis also leads to bone infarcts and hence a lot of weakened areas within the bone itself and a propensity to actually have avascular necrosis at a very young age. The effect of the bone marrow infiltration itself could lead to anemia, thrombocytopenia, leukopenia, which can happen simultaneously or present themselves independently in the pediatric age group. Anemia and thrombocytopenia, when they happen simultaneously, it is more indicative of bone marrow infiltration, while thrombocytopenia is more when it happens independently, it is commonly seen in non-splenectomized patients. Lymphopenia is detected more commonly than neutropenia at presentation and may help in differentiating Gaucher's disease type 1 from hematological malignancy, in which the neutrophils are seen to be in the ascendancy or increased numbers. When it comes to the classification, we can portray it to be clinical manifestations with which Gaucher's disease in the different types actually presents within the patient groups. Gaucher's disease itself is categorized based on the clinical presentations in the patients, and it is of three different clinical types, which are distinguished by their clinical features, the course and ethnic predilection of this disorder. Though this presentation will be concentrating more on the type 1, which actually affects the skeletal system more, This present slide gives us an overview of the different types of Gaucher's disease, and points to be noted include the fact that the ethnic predilection of type 1 is more in the Jews, while the type 2 and type 3 has more diverse presentation, with the Spanish and the Palestinian population getting affected with type 3C. Other points to be noted include that type 2 being a more severe form of the Gaucher's disease, affecting children within their first 1 year, and also has a more diverse mutation, and the progression of the disorder into a more severe form is more seen in type 2 Gaucher's disease. The other points to be noted include the common presentation, which includes hepatosplenomegaly among all the types, but type 2 and type 3 have more of neurological and cardiac manifestations as compared to type 1, which has more hematological and skeletal manifestations. As mentioned earlier, the points to be noted, which are actually features which are only seen in Gaucher's disease type 2 and 3, are more of neurological issues, which include the eyes and also the higher cognitive functions in the form of developmental delay or a subtle cognitive issues, with a few issues in the eye, which include strabismus or a supranuclear gaze palsy and a progressive dementia, which actually are seen only in type 2 and type 3. Type 3 also involves the cardiovascular system, and this is a point to be noted and to be taken home as well. As far as patients with Gaucher's disease type 1 is concerned, they more commonly present in the orthopedic clinic following bone issues, but this is following a splenectomy which is done following investigation for a more common diagnosis in the form of either a malignancy or a traumatic splenic rupture which they might have had earlier. When it comes to the Gaucher's disease of the bone, it is associated with a high degree of morbidity in the patients who actually present with inability to perform day-to-day activities of living as well. And there are a few patients who are the lucky ones who have radiological evidence of the bone disease but without any symptoms. When it comes to the skeletal disease, it is characterized by a diffuse bone pain which is punctuated by painful crisis which occurs due to osteonecrosis of the major joints in the body, more commonly involving the knee, the hip, and the shoulder joint. This osteonecrosis or avascular necrosis eventually leads to a joint collapse. Since it's a very rare disorder, there is a Gaucher's registry which is being maintained for this rare disorder, and there are currently 1698 patients registered, among whom 63% have had bone pain, while 33% have had osteonecrosis or bone crisis as their presenting symptoms. The most important take-home message is 94% of these patients have had radiological evidence of skeletal disease, which shows that the disorder itself generally manifests itself on the skeletal system, especially the type 1 Gaucher's disease. Only 8% of the 1698 patients have had joint replacement, and whether this helps or not is something which has not been proven by any studies. And when it comes to the bone, as mentioned earlier, osteopenia is most common presentation, followed by osteonecrosis or avascular necrosis of the major joints in the body. And following the avascular necrosis, the characteristic deformities which are seen in Gaucher's disease itself is the Erlenmeyer-Flask deformity, which is owing to the abnormal remodeling happening within the bones and also due to the dysfunctional osteoclasts which are seen in this particular disorder. This is followed by bone marrow infiltration and bone marrow fibrosis, which is generally picked up on MRI scans of the long bones of the body. And when it comes to the joints commonly involved, the first in the order of decreasing frequency is the knee joint itself, followed by the hip, and last but not the least, the shoulder joint itself. When it comes to radiological findings in patients with skeletal manifestations of Gaucher's disease, in the Gaucher's registry itself, among the 1698 patients, the most common manifestation as far as skeletal manifestations are concerned in Gaucher's disease is Erlen-Meyer-Flass deformity, which is seen in about 45% of the patients registered in the Gaucher's registry. This is followed closely by osteopenia, which is generally picked up on a DEXA scan, and this is also seen in 45% of the patients. While 40% of the patients actually have had bone marrow infiltration, which is generally picked up on MRI scan, and the other issues, which include fractures and fragility issues, are seen in 15% of the kids. The least common skeletal manifestation is lytic lesions, which are more or less seen in malignant changes in the bone. But as far as the Gaucher's disease is concerned, lytic lesions are seen in less than 10% of the patients. When it comes to the lab findings which aid in the diagnosis, the Gaucher's cells themselves are a cardinal feature of this disorder, which is seen on microscopy. And these cells generally appear as wrinkled tissue paper appearance. And while on electron microscopy, there could be inclusion bodies which are filled with glucocerebrosidase. When it comes to the blood works, there is a possibility of thrombocytopenia and anemia, while the liver enzymes can be slightly elevated. The serum ACE is an incidental finding and cannot be used as a diagnostic test, but definitely there is a ketotriosidase, which is an enzyme of unknown natural function, which is secreted from the lipid-laden macrophages and can be used and is a characteristic finding of patients with Gaucher's disease. When it comes to the diagnostic tests of choice, it would definitely be an enzyme analysis or a mutation analysis, where an enzyme analysis would lead to a conclusion of a reduced glucocerebrosidase activity in the peripheral leukocytes, while a mutation analysis, which involves a targeted DNA analysis, is one of the most favored diagnostic tests of choice when it comes to the diagnosis of Gaucher's disease. This is a typical appearance of a bone marrow aspirate from a patient, which actually shows the typical Gaucher cells with a wrinkled tissue paper appearance with an enlargement of the macrophages owing to the lipid accumulation happening within them. The other ways in which we can understand if the child is more prone to the Gaucher's disease is through prenatal diagnosis in the form of amniocentesis or chorionic villus sampling, which are done more frequently in the recent times. Newborn screening for this rare disorder is controversial as it is done only for a child who the clinician feels is more prone to it, while genetic counseling is another way by which we can understand the recurrence rate of this rare disorder. This is owing to the fact that the recurrence risk for a couple who has a child with Gaucher's disease is 1:4 if both the parents are heterozygotes for this disorder, while it increases to 1:2 if one of the parents is actually affected with this disorder and the other is a heterozygote for this. When it comes to the differential diagnosis, it is based on the signs and symptoms and the clinical manifestations of the patients themselves. When they present with splenomegaly, anemia, and thrombocytopenia, the differential diagnosis involves leukemia, lymphoma, or inflammatory diseases such as rheumatoid arthritis, and other storage disorders, which include Niemann-Pick types, which are A, B, or C type. When the patients present with skeletal manifestations in the form of osteopenia, pathological fractures, and bone pain, the differential diagnosis would then point towards metabolic bone diseases in the form of rickets, vitamin C deficiency, copper deficiency, sickle cell disease, or the Paget's disease. When it comes to the treatment, I would be more talking only of type 1 Gaucher's disease, and the treatment involved is actually enzyme replacement therapy in the form of a mannose terminated recombinant beta glucosidase, which actually is the enzyme depleted in this disorder. The dosage involved is about 60 international unit per kg, which is administered intravenously on every alternate week. Evidence has shown that bone involvement or the bone changes in the form of osteopenia can be reversed if intervened early enough. The other artificial enzymes which are FDA approved include glucerase alpha and taliglucerase alpha, but these are generally employed in type 1 Gaucher's disease, while type 2 and type 3 there has been no evidence that enzyme replacement therapy actually helps, as the neurological progression cannot be altered in these kids. More or less, it has a palliative role and can be tried, as there are not many other options available to stop this progression of this rare disorder. The other alternative options for enzyme replacement therapy is to use agents such as miglustat, which is an oral substrate reduction agent which actually inhibits glucosylceramide synthase, which in turn inhibits the production of glucosylceramide, which is the culprit which gets accumulated in this disorder. The other option is also a bone replacement therapy, but this is associated with significant mortality and morbidity in the patient, and patient selection becomes the key then. Thank you.